We have our first speaker is Tom Todoran. He's been with us at MUSC for about 4 years now. He works down the hall from us in IR and cardiology, and we're glad to have him. He's from Duke. I'm wearing my North Carolina tie in your honor. He trained at the Brigham, and he's going to talk about renal denervation in the treatment of hypertension. Thank you, Tom.
Thank you, Chris, and I'd like to thank the planners for inviting me to participate in this meeting. It's been a great time. So as Chris mentioned, I'm going to talk about renal denervation for treatment of resistant hypertension. I'm going to go through, these are my disclosures. I'm the site investigator for Hypertension 3 and 4, which are clinical trials using renal denervation. This talk will include discussion of unapproved investigational devices. So we're going to talk a little bit about the background of resistant hypertension, go through renal artery anatomy and physiology. I'm going to discuss clinical trial results of catheter-based sympathetic denervation in humans for treatment of resistant hypertension, focusing mainly on the Symplicity catheter, which is the most studied. We'll also talk about emerging technologies with second-generation catheters and then potential benefits beyond treatment of resistant hypertension. So I think a few years ago, I think the hype would have been talking about renal artery stenting. You can see here that by this angiogram on the top that this patient has renal artery stenosis, and a few years ago, probably a lot of us would be stenting this, and I know we're going to talk about that a little bit next, but now the big hype is sympathetic overactivity and moving from stenting to singeing or radio frequency ablation of the arteries. So resistant hypertension, by definition, is a failure to achieve goal blood pressure, which is less than 140/90, using 3 different drugs with pharmacologically complementary mechanisms, one of which is an appropriately dosed diuretic. All 3 drugs are given at maximally tolerated doses, and patients must adhere to adequate and appropriate drug regimen. If you look at hypertension, it's the single largest contributor to death worldwide. For every 20 over 10 millimeter mercury increase in blood pressure, this correlates with a doubling of 10-year cardiovascular mortality. It dramatically increases risk of stroke, heart attack, heart failure, and kidney failure. And if you look at the epidemiology, only about a third of all treated hypertension patients are actually controlled to target blood pressure. And it's a high prevalence, 1 in 3 adults. So even small risks or small reductions in blood pressure can reduce cardiovascular mortality. This meta-analysis of 61 prospective observational studies showed that 4 millimeter reduction in blood pressure in the office resulted in a 10% reduction in risk of stroke mortality and 7% reduction in risk of ischemic heart mortality, disease mortality. And these are our current guidelines for treating hypertension in the United States. Essentially, we start with lifestyle modifications. These are listed here on the left of the screen. These include weight reduction, a DASH diet, reducing sodium intake, increased physical activity. Then if you're still above goal, then initiation of drugs. And really what this talk focuses on, it focuses on the panel down below. If you're not at goal and you're on maximal medical therapy. So what are our options there? It's been shown that activation of the renal sympathetic nerves is present in essential hypertension. In this study by Goldstein, you can see on the left, patients with hypertension had increased levels of norepinephrine compared to normotensive patients on the right. And you see the slope of these lines, or slope of these various patients, hypertensive versus normotensives. And this is the schematic of the sympathetic innervation of the kidney with the brain, blood vessels, and heart. So afferent and efferent sympathetic nerves are activated. They result in vasoconstriction, increased heart rate and contractility, increased renin release, activation of the renin-angiotensin, aldosterone system, vasoconstriction, and increased sodium resorption and water retention. All this results in increased blood pressure. So when this gets out of control, that's the sympathetic drive that results in the resistant hypertension. And we have medications that target each of these. Calcium channel blockers or vasodilators. We have beta blockers that slow the heart rate down. And we have a whole host of drugs that either work through central actions with the sympathetic system, such as clonidine, or angiotensin receptor blockers that work at the kidney level, diuretics that work at the kidney level. So our medicines are really targeted at all these endpoints to try to reduce blood pressure. If you look at this animal study in, I believe it was pigs, compared to controls, which are untreated, if you did catheter-based denervation or surgical denervation, there was a reduction in tissue norepinephrine levels. So based on autopsy studies, 90% of all nerves exist within about 2 millimeters from the renal artery lumen in the adventitia. So what this does is this allows for access of the renal arteries or the renal nerves via the renal artery to deliver energy, and it makes this feasible. Back in the day, before in the 1930s or 1920s, actually before there were medications for treating hypertension, they actually did sympathectomies. So they would operate on patients, take out their sympathetic ganglion to treat their blood pressure. I'll talk about that in a little bit, and its lack of success. But this really allows catheter-based approach to sympathetic denervation, and it's done by standard technique. You see a catheter going up the femoral artery there, and you engage into the renal artery, and then on the I don't know if I know where the pointer is on here. Yeah. If you basically, this is the device in the cross section there for the renal artery, and you deliver the energy 2 millimeters out or beyond and disrupt these nerves. These nerves are in a mesh network along in the adventitia, so you don't disrupt them all, but you actually disrupt some of the nerves. So here are the trials. The Symplicity Symplicity catheter was the largest catheter studied. It's the initial first-generation catheter, initially by Ardian and then bought by Medtronic. It was done, Symplicity Hypertension 1 includes first-in-man studies and a series of pilot studies. This led to Hypertension 2, which is a randomized trial, then Hypertension 3, which is a pivotal trial, and then Hypertension 4, which is an ongoing study in the U.S. Here are, this is Hypertension 1 and 2, the patients and methods. So Hypertension 1 in the panel on the left was a proof of concept study at 5 centers in Europe and Australia, and then it was eventually expanded to 19 centers, from 45 patients to 153 patients. Mean age was 58 years old. That's why. Mean age was 50 years old, and most were white, about half females, with a baseline blood pressure of 177 over 101, and they were on 4.7 meds. The inclusion criteria were basically they had to have resistant hypertension, so greater than 150 or 160 millimeters of mercury on at least 3 antihypertensives, including a diuretic. And the primary endpoints were office blood pressure and procedural safety before and at 1, 3, 6, 9, and 12 months. Hypertension 2 was a randomized trial at 24 centers in Europe, Australia, and New Zealand. 106 patients, 52 underwent renal denervations, and 54 were control group, which is just medical therapy. So it was a randomization to renal denervation plus medical therapy to medical therapy alone. And these are very similar demographics, and the inclusion criteria were the same as Hypertension 1. And the primary endpoint was a change in office blood pressure at 6 months. So here are the results. The efficacy outcomes. On the panels on the left were Hypertension 1. The top panel was their initial cohort, and then below the expanded cohort. So from 1 month, you can see there was a statistically significant reduction in blood pressure, all the way out to 12 months. And then this persisted up to 36 months. So this showed that it was efficacious and durable. And even in the randomized trial, same results. You started seeing a change at 1 month, and then out at 6 months, you had a statistically significant reduction in blood pressure of 32/12 in the renal denervation group compared to control. If you look at the endpoints of safety, the most common complication was access site complication. There were no deaths, no major adverse events. And this just illustrates that in an expanded cohort of 600 patients across the world, there were really no major vascular complications, no evidence of renal artery stenosis. So it's based on the early trials, it's been shown to be effective and durable and safe. A notable limitation of these studies is that there were no screening for secondary causes of hypertension, particularly white coat hypertension. Patients weren't blinded and the clinical staff weren't blinded. So when someone went back and saw someone, it's possible that they could change their medicines if they weren't blinded. There was no sham control. And there was a lack, this is a big criticism, is there was a lack of 24-hour ambulatory or uniform 24-hour ambulatory blood pressure monitoring, in particular for white coat hypertension. And it's been known that basically an ambulatory reduction in blood pressure is more predictive than office blood pressure. And then finally, less than 20% of participants received an aldosterone antagonist. So the purists would say that you don't have resistant hypertension unless you've failed aldosterone antagonist therapy. So Hypertension 3 was actually designed, the U.S. pivotal trial designed to try to confront many of these limitations. It's a multi-center trial, 90 centers, which we were a site. It's prospective, randomized, blinded, sham-controlled study. So it's a sham-controlled study. This is the first, I believe, the first interventional trial where we actually had a sham procedure, which just included an angiogram, and 530 patients with treatment-resistant hypertension. The treatment group received the renal denervation plus baseline medicines. Control group, which was a sham procedure that included just an angiogram, and then baseline medications, and then primary outcomes, again, blood pressure at 6 months. And this is just a flow diagram showing that. And I think the key here is that it was very rigorously designed, and that patients and staff were blinded. And this, I'll go over this a little bit later, but it was very, very rigorous screening to get these patients in. They didn't just show up with a blood pressure of 160 and they weren't to be enrolled in the trial. So in summary, this was a office blood pressure over 160 on greater than 3 medications, normal renal function, no renal artery anatomy exclusion, so they couldn't have renal artery stenosis. They were very strict with this as well. They had to have normal renal arteries. And then patients must remain blinded and no changes in medications unless medically necessary. So on January 9th, much to everybody's surprise, Medtronic released this press release that their pivotal trial failed to meet its primary efficacy endpoint, although it did meet its safety endpoint. So many people were very, very surprised about this around the country. This has not been published yet, so we don't really know what the data is. I will talk a little bit about potential reasons why it didn't meet its endpoint. You know, it's possible that renal denervation just doesn't work. You know, we're barking up the wrong tree. Maybe it's a problem with study design, although I think that's unlikely. I'll show a few slides here that shows it was very, very well designed. Maybe patient selection. You know, the actual prevalence of resistant hypertension is very low. It's almost 10%, 12%. So maybe these patients actually don't have resistant hypertension. Maybe the patient population can't be, we don't have the same patient population in the US as in Europe. It's primarily a white population where we have many African Americans in the US actually have, more prevalent hypertension. Again, we don't know the numbers, I'm only speculating. And it's possible that this device just doesn't work, so maybe second generation devices may be better. So I'll go through each of these. So maybe renal denervation doesn't work. Back in the 30s, this is from Mass General, they looked at their sympathectomy, and I guess the question is, was the writing on the wall? This study here, if you look at actually doing taking out the sympathetic ganglion, it actually showed that it didn't really reduce blood pressure all that well. If you look at the down here, almost 50% of the patients didn't respond, and this is with removing all the sympathetic nerves. So it's possible that it just doesn't work. This is a trial design, as I mentioned, is very rigorous screening, several points where the patient could fall out. They have their initial screening. They do a home diary to confirm that they're compliant. They come back in, so they have to be over 160 on a second visit. They go home with a 24-hour ambulatory monitor, and then they have to meet a blood pressure over 135. Very rigorous screening, so I don't think it was a trial design flaw. And again, here, I think the key is that people were blinded, and they received a sham procedure. So again, I don't think that there was a trial design. I think it was a very well-designed trial. So what about the patient population? If you look at the National Health and Nutrition Examination Survey, as I mentioned, it's estimated about 12% of patients have resistant hypertension. So maybe we just don't have the right patients. Maybe their hypertension is a result of their comorbid disease, sleep apnea, smoking, obesity, poor diet, increased sodium in their diet. Adherence is a big issue with many of these patients. You can see here on the panel on the right, this is an assessment of adherence by toxicology studies where 400 patients were referred for resistant hypertension. And after you actually kind of drill down, you end up with about 76 patients who meet criteria. And among these 76 patients, half of them were found to be non-adherent. So really, again, about 10% of the patients that are sent for resistant hypertension don't have resistant hypertension. They were prescribed the medicines, they're not taking them. So it's possible that we just don't have the right patient population. What about maybe the device doesn't work? This is a very busy slide from a review article that I wrote. But basically, there are many of different devices. I won't go through these, but they're looking at different platforms, having increased electrodes to try to be more, to make renal denervation easier, faster, and more effective. And so, looking at this, there are several feasibility studies with these second-generation devices, but I think we'll be cautioned in that this looks very similar to Hypertension 1 and Hypertension 2. The Lighten 1, which is St. Jude up here on the top, and Reduce, which is Vesics, those two companies actually have ongoing studies in the US that are put on hold now until Hypertension 3 is published so they can try to learn from that. I don't think that they're going to pull the trial completely, but they'll probably modify it based on what's published. But again, you see here statistically significant reduction in blood pressure. These are non-randomized trials. The Vesics has the most patients in this non-randomized group of 140 patients. And they also, these two include ambulatory blood pressure reduction. So it may be possible that these are better devices, that they are more effective in terms of renal denervation. However, if you go back again and look at, we caution our excitement about this, because if you go back and look at the surgical sympathectomy, which is, you would argue is complete, even many of those patients didn't respond. So where are the future directions, potential benefits beyond blood pressure? There's some small studies on glucose metabolism, obstructive sleep apnea, arrhythmia, and heart failure. So again, if it's maybe a small group of patients with resistant hypertension and some people with comorbid diseases that actually could benefit from this. This is a study of 50 patients who underwent renal denervation, and it showed that, or at least in these patients who did have renal denervation, they had improved glucose metabolism and insulin sensitivity as measured by fasting glucose levels, which were lower, C-peptide levels, which were lower, and insulin levels, which were also lower. What about obstructive sleep apnea? Again, these are small studies, 10 patients with refractory hypertension and obstructive sleep apnea. They underwent renal denervation, and this was associated with improved sleep apnea severity as measured by, these are individual patients, but as measured by the reduction in apnea-hypopnea index with a median reduction of 16.3 versus 4.5 events per hour. Arrhythmia, there are many arrhythmia studies ongoing. This is one that's published, 27 patients with paroxysmal atrial fibrillation. They were randomized to get an ablation only versus an ablation and renal denervation. Patients who had the renal denervation were 60%, almost 70%, again small, but 70% had freedom from AFib burden versus 30% in those who just had the vein isolation only. And then finally, heart failure, which I think is probably going to be the most promising group of patients that may benefit from this. We know with heart failure is a disease of sympathetic overdrive, and these patients are end stage. You know, they're essentially the end stage of the hypertension over increased sympathetic activity. In this small study, again, I think it's like 10 patients. You see that there's an increase in their 6-minute walk distance of 27 meters. And interestingly, there's no drop in blood pressure in these patients. You know, people with systolic heart failure typically run systolic pressures in the 80s, 90s. So you'd worry that if you do denervation on them that they're going to drop their pressure, become hypotensive, but these patients didn't. This is a very busy slide, but I went to clinicaltrials.gov, and there are numerous trials. These are all the non-hypertension trials, and these are all the hypertension trials. So there are many, many trials ongoing. Again, I think many are put on hold until we get our data from ACC. So in summary, I'd like to finish that preliminary non-randomized data for renal denervation looked to be promising therapy for resistant hypertension. Unfortunately, Symplicity HTN-3 did not meet its primary efficacy endpoint, but did meet its safety endpoint. And then preliminary data using these second-generation devices, RF, ultrasound, have shown these devices to be promising, although with caution, given the hypertension 3 results, and randomized trials are required to confirm safety, efficacy, and durability. And then there are potential benefits to find patients that may, you know, that renal denervation may benefit specific patient populations. But again, these need to be randomized in larger randomized trials. And so I guess this talk will be to be continued at ACC in the end of March. And so we'll see. Hopefully there's more to come. And as I thought about this, I probably should have retitled my talk, although I didn't want to change it, Renal Denervation, Cautious Optimism. Thank you.